Hello, everyone. It's now 2 p.m. Eastern Time. You've joined the Justice and Mental Health Collaboration Program Fieldwide webinar on understanding the expanded Risk-Need-Responsivity model, supervision, programming, and dosage. To allow for additional sign-ins past the hour, we're going to be starting this webinar in a few minutes. Thanks. All right, looks like it's slowing down for people coming in, so I'm going to get started. Good afternoon, and thank you for joining today's Justice and Mental Health Collaboration Program Fieldwide webinar on understanding the expanded Risk-Need-Responsivity model, supervision, programming, and dosage. My name is Stephen Deal, and I'm a senior policy analyst here at the Council of State Government's Justice Center. I'll be moderating today's webinar, which is hosted by the U.S. Department of Justice, Bureau of Justice Assistance, and the Council of State Government's Justice Center. Next slide. And to just give you an overview of today's webinar, first we'll do introductions of our speakers. You will hear a presentation about the overarching principles of the R&R model, including the 18 components of the expanded model and guidelines for accurate, fair, and transparent R&R assessments. And towards the end of the webinar, we'll have some time for questions and answers. At any time during the webinar, you can ask a question by clicking on the Q&A button on the bottom of the screen and entering your question. This includes both technical and content-related questions. We will try to reply to technical questions in the chat as we go. For the content-related questions, we'll keep a running list and address them at the end of the webinar. We'll do our best to get through as many questions as possible, and if you encounter technical or audio problems during this webinar, please click on that link that we shared within the chat. Please understand that there are some technical issues we may not be able to resolve, but we are recording the webinar and we'll post it along with the PowerPoint slides on our website within 1 to 2 weeks. Next slide. Today's presenters are David A. Diamora, who is a senior policy advisor with the Council of State Government's Justice Center, myself, and Maria Fryer, Justice Systems and Mental Health Policy Advisor, Substance Abuse and Mental Health, Bureau of Justice Assistance with the U.S. Department of Justice. And the next slide I'm going to kick to her.
Great. Thank you, Stephen. Welcome, everyone, today to this webinar. We're really happy to have you. Just a little bit about the Office of Justice Programs and where the Bureau of Justice Assistance sits in this office. And you can see the Bureau of Justice Assistance is located within the Office of Justice Programs we call OJP. And OJP provides a wide range of services to the criminal justice community in the form of grants, training, technical assistance, and research. And you can see within OJP, we have BJA, our sister organization that collects statistical information, BJS, NIJ, the National Institute of Justice, the Office for Victims of Crime, OJJDP, that works with juvenile justice and delinquency prevention, and then the SMART office. Next slide. So a little bit about BJA and our mission, which is to provide leadership and services in grant administration and criminal justice policy development to support state, local, and tribal justice strategies to achieve safer communities. BJA works with communities, governments, and nonprofit organizations to reduce crime, recidivism, and unnecessary confinement, and promote a safe and fair criminal justice system. Specifically, BJA provides funding to support law enforcement, combat violent and drug-related crime, and combat victimization through the development and implementation of policy services and sound grant management. BJA strengthens the nation's criminal justice system and restores security in communities. Next slide. So this is our director, Carlton Moore. He was appointed by President Biden in February of 2022, and Director Moore leads the BJA programmatic and policy efforts on providing a wide range of resources, including the training and technical assistance I mentioned, to law enforcement, courts, corrections, treatment, reentry, justice information sharing, community-based partners, and he does travel quite a bit around the country to speak to states and tribes and local communities, and to talk about our partnerships and how we're, through our grants and technical assistance, improving safety and reducing recidivism. Next slide. So the 5 major strategic focus areas by BJA. On this slide, you can read more about the 5 primary strategic focus areas, many of which relate directly to the work in grant programs that BJA administers. And these include a strategic focus on building trust and ensuring effective criminal justice systems, reducing recidivism, as I mentioned, and unnecessary contacts with the criminal justice system, as well as utilization of evidence-based strategies, increasing program effectiveness, and ensuring organizational excellence. Next slide. And again, these are the 4 areas that BJA focuses on with our collaborative partners, such as the Council of State Governments Justice Center. Next slide. Okay, so I'm going to kick it back over to CSG. Thank you so much for being with us today, and we hope to see you in future webinars. Thank you.
Thank you, Maria. I'm going to give some background on the Council of State Governments Justice Center. The Justice Center is a national nonprofit, nonpartisan organization that combines the power of membership association representing state officials in all 3 branches of government with the expertise of a policy and research team focused on assisting others to attain measurable results. Our staff develops research-driven strategies to increase public safety and strengthen communities. Next slide. How we work is bringing people together and driving the criminal justice field forward with original research, building momentum for policy change, and providing expert assistance to the field. Next slide. Below are our goals. Oh, sorry, can you jump back one? Thank you. Below are our goals for breaking the cycle of incarceration, advancing health, opportunity, and equity, and using data to improve safety and justice in the field. Next slide. The Council of State Governments Justice Center is committed to advancing racial equity internally and through our work with states, local communities, and tribal nations. And next slide. The Justice and Mental Health Collaboration Program, or JMHCP, as we call it, was established in 2005 and is funding the training today for the field at large. Some of the attendees in this training may currently have a JMHCP award or may have received one previously. Next slide. We're back to our presentation outline. So for our presentation, I'm going to turn it over to David A. Diamora.
Thanks, Stephen. Hi, everybody, and good morning for those of you on the West Coast, and good afternoon to the rest of you. I'm pleased to be able to chat with you this afternoon and to talk about the risk-need-responsivity model and risk and need assessment. And what we're going to do during this conversation is basically talk about the 18 components of the expanded R&R model. R&R has been around for a good 30-odd years now, and most people know R&R as in risk, need, responsivity, and they don't actually know the other components that are wrapped around all of that in terms of the expanded model. So we're going to go through all of these different areas. When we get to the part of structural assessment in terms of assessing R&R, et cetera, we are going to take a slight detour, talk a bit more in depth specifically about risk and needs assessment and what the issues are around that. And then we will come back and complete the afternoon's conversation with program delivery and self-practices and organizational skills. Next slide, please. There are three overarching principles in the risk-need-responsivity model. The first one is respect for the person and the normative context. The second is the psychological theory that underpins it. And the third is general enhancement of crime prevention services. Next slide, please. So looking first of all at the issue of respect for the person and the normative context. Services under this model are to be delivered with respect for the person, including respect for personal autonomy, being humane, ethical, just, legal, and otherwise normative. It's important to understand this principle in the R&R model, particularly for those of us who work in or have worked in the behavioral health field. There have been times in the behavioral health field where there have been concerns about the R&R model, with it being seen only as a criminal justice model or it being seen as a model that doesn't take into account the needs for respect, for personal autonomy, for humanity. But in fact, when the model is done correctly, when there is fidelity to the model, those needs, those issues are indeed met and are a cornerstone of the model itself. Secondly, some norms may vary with the agencies or the particular settings within which the services are delivered. For example, agencies that are working with youth may be expected to show exceptional attention to education issues and child protection. Agencies working with women may be particularly expected to know trauma-informed treatment more so than perhaps other agencies might be expected to know that. And we could sort of go on and on about a lot of different areas. And so it's important to understand that it's not a one-size-fits-all and that there are different knowledge components that are necessary within the model. And then thirdly, mental health agencies in particular may attend to issues of personal well-being. In other words, one of the big arguments historically was, well, R&R talks about criminogenic factors, and it talks about people that have high risk or needs that are criminogenic, but it ignores the other important components. That actually isn't what the model was designed to do. What the model said was that intensity of treatment to deal with criminogenic factors is related to the degree of risk, and we'll come back to that. It never suggested that if people, for example, need housing or have food insecurity or have significant mental health or substance use that's not related to the crime, substance use issues, that they shouldn't be given access to those programs or they shouldn't be given the supports. It's giving the right supports to the right people at the right time. Next slide, please. Second principle has to do with psychological theory, which basically says that the programs need to be based on solid psychology, not pop psychology, not the flavor of the week, not a lot of, quite frankly, silly programs that we often see that take root in the criminal justice system. And so fundamentally, what it talks about is general personality and cognitive social learning, which is one of the reasons why we talk about cog programming. And so there are two issues here. One is the issue of cognitive programming, and lots of folks, if folks have a high criminogenic need, cognitive programming is part of what needs to be given to them. And cognitive programming means things like thinking for a change, or it might mean something like reasoning and rehabilitation or decision points. There are a number of those programs that are out there that don't necessarily require a clinician to provide that programming, and they were designed as such. In addition to that, there's cognitive behavioral treatment. And many of the individuals that we work with, of course, do need some type of mental health or substance use treatment. And generally speaking, for this set of clients, the cognitive forms of treatment tend to be the most successful in terms of looking at outcomes. And then thirdly, we don't want to forget about the issue of crime prevention. There needs to be general enhancement. We certainly do want to have a reduction of victimization. That's a legitimate objective of service agencies, which include both agencies within the judicial legal system and outside of the judicial legal system. I would argue there's nobody that works in any human service whose goal is to not worry about crime prevention. We all want to make sure that the people that we're working with are as healthy as possible. And by definition, if they're as healthy as possible, the likelihood of them committing crime drops dramatically. Next slide, please. So we'll talk now in terms of an overview of the criminogenic risk, need, and responsivity model, and go through those different components that I was just mentioning at the beginning. So next slide, please. So first of all, let's just talk about the thing that most of us probably have heard if we've been in the field for a while, which is the middle part of that, right? Risk, need, and responsivity. Risk in this model is the probability of an event occurring. To be clear, risk does not mean harmfulness or seriousness of the event or violence or dangerousness. It means the probability of some type of recidivism, maybe the probability of being arrested for a new crime or convicted for a new crime, or possibly being returned to custody for a technical violation or violation that is not the result of new crime. And the idea behind the risk construct is that you want to match the level of service to the person's risk to reoffend. You want to provide those folks at moderate or high risk of reoffending with the cognitive programming that I was mentioning. And you want to keep low risk folks out of those services. First of all, we can't lower their risk anymore if they're already low risk. Second of all, mixing them with folks who have less pro-social thinking and behaviors, bad plan. We're not going to increase their strengths. We're actually going to increase their risk to offend or reoffend by connecting them with others who are more likely to do so. And it's a waste of resources, as well as an inappropriate use of the criminal legal system to respond to an issue. They may need mental health services. They may need some other services. Nobody's saying don't do that. But what we don't want to do is have an intensity of services designed to lower criminogenic risk for those individuals who do not have a moderate or high level of criminogenic risk. One of my several soapboxes that I will go on as we're talking is that one of the problems that has happened in our work is that we have, over the course of the decades, gotten a bit lazy, and we talk about risk, and we conflate risk with dangerousness, and we conflate risk with how rigid we need to be with individuals. That wasn't what the construct was about. The construct of risk had to do with what's the intensity of service that is needed. Yes, supervision is one component, but supervision by itself does not, cannot, will not lower the risk of somebody's recidivism. The supervision is what we utilize, hopefully when we do it well, what we utilize to have sort of a temporary set of guardrails around someone while they may not be able to make good decisions themselves. And the services that we then provide are those services to help them develop the ability to make pro-social or positive or good decisions themselves, as opposed to somebody on the outside saying, I'm going to make sure you behave, which fundamentally is not effective, and certainly by itself is not effective. Next slide, please. The second has to do with criminogenic need. Criminogenic need also does not mean a risk of violence or dangerousness or factors that are historical and unchangeable. There are factors related to violence and there are assessments related to violence, but the R&R model wasn't specifically developed to focus on violence. It was looking at what the potential for any new crime or new issue that would come up might be. In addition, what it then looks at are what they call criminogenic needs, which are the dynamic factors or the dynamic characteristics that are associated with a person's risk of reoffending. And they include a number of different things that we'll go through in just a moment. But it is important to understand that when we are working with individuals who have these particular criminogenic needs, we have to respond to those, because if we don't, no matter what else we respond to, we will not lower their risk. Now, there are times when we need to respond to other issues in order for them to benefit from the response to lower their criminogenic need. And again, we'll come back to that. Next slide, please. Responsivity is the most important and sadly least understood component of the risk-need-responsivity model. Responsivity can be clinical syndromes, it can be impairments, it can be social service needs. They don't typically cause crime. There's not a direct relationship, a causal relationship, but they can certainly interfere with the individual's habilitation. If I don't know where I'm going to sleep tonight, I'm probably not going to be very good at getting my homework done. If I am starving, I probably am not going to be focusing on what are my cognitive distortions. So they are very important and genuine issues and needs that will have to be met that fall under this bucket, if you will, of responsivity. And it includes, as I already mentioned, homelessness or serious or persistent mental illness, drug or alcohol cravings, withdrawal, PTSD, traumatic brain injury, and many others. The concept of responsivity is to maximize the individual's ability to learn from a habilitative intervention by providing a cognitive behavioral program or intervention and tailoring that intervention to the person's learning style, to their motivation, to their abilities, and to their strengths. One of the other things that you see in terms of a failure to have fidelity to the R&R model is that many programs want people to treat who already have decided that they need all of the help that they need. And so basically 60% of the work is already done. In reality, for the types of clients that we work with, given where they are in their lives, given what the issues are, part of our job is actually engaging them and working with them to increase their motivation for change. Now, there are two components to responsivity. One is general, which is the use of cognitive social learning methods, as I've mentioned, to influence behavior. And the other is specific. And we've gotten pretty good at the general over the last 30 odd years or so, 40 years now. We've gotten pretty good at that. We know it's cognitive programming. We know there's a variety of types of cognitive behavioral treatment that make a difference. We're really good at that. I mean, generally speaking, we know what those things are. We have not done so well at specific responsivity. We have not done very well at modifying strategies in accordance with the strengths and the motivations and the readiness to change of the individuals, or their particular personality issues, or their mental status and learning ability, their learning style, their specific circumstances, cultural differences, racial and ethnic differences, demographics of individual cases. We've not done a good job about that. One of the failures of a lot of what we've developed is that they've been developed by middle-class white folks. And, you know, not to pick on middle-class white folks exactly, but the reality of it is that when that's who's developing that, and you don't adapt those things appropriately for folks who aren't in that same grouping, then you aren't giving people the things that they need or giving them the things that will work the most effectively for them. And it is one of the things that it's only in the last decade we've begun to understand. It took us way too many years to figure that out. And we are still in the early, in my view, we are still in the early stages of making those adaptations and those changes. There are some very exciting things happening but you do not see it consistently happening throughout the country yet. Next slide, please. So what about those major risk factors, what we historically called the central eight? We now they're still called the central eight, but in reality, it's kind of the big seven. And that's because the eighth one, or the number one, is a static factor. It has to do with criminal history, has to do with issues around number of arrests, number of convictions, types of offenses. Couple of things about that. This is one of those areas where valid concern has arisen about, are we overestimating risk of some individuals because they are more likely to be arrested by virtue of nothing other than the color of their skin? And so that's a very valid issue, which we'll come back to when we talk about risk and needs assessment. But one of the reasons why it's in the separate or in the left-hand box here is that we can't do anything about that, okay? If we want to look at that, it may help make some determination about initial level of intensity of service. But after that, it's meaningless. Now, that may sound odd, but what I mean by that is for those of us who are supervising those individuals, for those of us who are treating those individuals, whether that's through cognitive programming, mental health, substance use, whatever it is that we're providing, the things that we can impact are not the static factors. The things that we can impact are the dynamic factors on the right. And dynamic risk factors is the original way of talking about need. And that's essentially what needs are. They're changeable factors that, when they exist, increase the potential for the individual recidivating, being engaged in further crime, or failing on supervision. By effectively working with those, we lower those risks. And what you see here are several of them. Antisocial personality pattern being the first one. To be clear, it is antisocial personality pattern, not antisocial personality disorder. Some people certainly have a diagnosable disorder, but many people have an antisocial personality pattern who don't have a diagnosable disorder. So it's not necessarily a, quote, clinical diagnosis, but it is a pattern of behavior that is antisocial in nature and a style of thinking that is antisocial in nature. The sort of silly example is, if you give someone with an antisocial personality pattern a problem to solve, their solution will almost always be criminal or antisocial in nature. That it doesn't matter what the problem is. That's what their first thought goes to, that sort of thing. The other factors include pro-criminal attitudes, meaning supporting of crime, pro-criminal associates, friends who are involved in crime, friends or associates involved, substance use disorder, family and marital stressors, poor school or work performance, and few leisure or recreation activities. Now, a couple of things. First of all, when the top three exist, if we focus on the bottom four and ignore the top three, we won't lower it. So that the argument of, well, substance use treatment will solve the problem is absolutely true for somebody who is low criminogenic risk and doesn't have the top three factors. But if they have the top three factors, we have to deal with those as well as the substance use issue. And this is true for family and marital, school and work, leisure and recreation. If we just deal with the bottom four, when somebody has the top three, that's a problem. Second comment. There have been a number of studies out there saying that folks who have mental health issues are more likely to have as many or more criminogenic risk factors than those who do not. That has led to some misunderstanding of what the intent of those studies were. It is true that when you look at a sample of folks, you see that. But what you see is that those folks are more likely to have more of the bottom four factors, not the top three. They're not more generally criminal. They have more of the things that we know that folks who have significant mental health and substance use issues have, right? Family and marital stressors, families who are tired of them, perhaps marital or intimate relationships that have fallen apart, problems in school and work, whether that's completing those things or keeping a job. and difficulties in terms of being involved in any type of leisure, social kinds of things with other appropriate folks. So while it is true on the one hand that when we look at the data, it is likely that there will be more of some of these things, it's really important to understand that the more is not the more criminal thinking stuff, but the more what we might argue as sort of social support kinds of things that you see here. Next slide, please. So when we're focusing on dynamic needs to create positive behavior change, what do we do? Well, what you see in the right are the need, meaning what it is that we do, and on the left you see the factors. These are hardly the only things, but these are the typical examples from Bonta and Andrew's work that they've done over the years. And so with an antisocial personality pattern, you're building self-management skills, you're teaching anger management, good decision theory, et cetera. With the pro-criminal attitudes, you're working with cognitive distortions, countering the rationalizations and excuses. And with pro-social attitudes, you want to build a more pro-social identity. With the pro-criminal associates, you want to replace with pro-social friends and associates. Once again, a comment. We went too far with this in some cases, and we've begun to understand that. And what I mean by that is we now know that some of the most powerful people to pair with people who are having difficulties are peers, P-E-E-R-S, those individuals who have had lived experience and who actually can understand and help these individuals, these folks, in ways that perhaps some of us cannot. And obviously, you want to make sure that there are folks who are doing well in their own life, that they are not currently involved in any type of criminal behavior, they don't have criminal thinking. But the idea that this person should never be around anybody else who's ever been convicted of something makes no sense. And that wasn't the original intent. The original intent, again, going back many years, had to do with, look, if you're hanging around with a whole bunch of other people that are committing crime, that's probably a bad plan. And you're going to more likely to commit crime. So we don't want you to do that. We want you to hang around with people who don't commit crime. There are people who have a prior criminal history who no longer commit crime and can be incredibly effective in helping these folks. Substance use disorder, obviously either reducing use or enhancing alternatives to using substances. Family and marital stressors might have to do with parenting, might have to do with needs in terms of intimacy development, capacity to care for others, poor school and work performance, again, enhancing work, study skills, nurturing interpersonal relationships, friendships at school or work, and encouraging for leisure and recreation activities, encouraging participation in pro-social activities, hobbies, and sports. Again, these are hardly all of the kinds of things that one can do, but these are a lot of the sort of core or basic things. And when we look at a lot of the cognitive programming that is out there for folks, again, thinking for a change, reasoning and rehabilitation, et cetera, they all, to different degrees, have components of all of these areas to help sort of teach folks about them and help them really move from what the dynamic risk factor is on the left to getting their needs met that are on the right. Next slide, please. So now we talk about the issue of risk and needs assessment. And whenever I talk about this, I always talk about risk and needs assessment. This is another thing we've gotten lazy about. We all talk about risk assessment. There are things that are only risk assessments. Those exist. But the vast majority of what we do, and when I say we, those of us that are working with people in the community in particular, we are doing a risk and needs assessment, not just a risk assessment. By shortcutting it and just talking about risk assessment, we are giving the most attention to what is ultimately the less important piece of it. Because the most important piece really is needs. I would argue that there might be a point in time when we should just drop the word risk altogether and just talk about needs assessment, and understanding that one of those needs might have to do with the level of risk, but that we need to change the thinking about it. If we're going to get lazy, we need to get lazy and call them needs assessments and not just call them risk assessments. So in terms of this, 4 steps. First of all, assessing risk, need, and responsivity, using structured and validated instruments to assess criminogenic risk, criminogenic need, and the responsivity factors. Secondly, identifying strengths. Again, something early on we did not do a very good job with in our early tools. Newer tools are really looking at these issues, assessing personal strengths and integrating those into the interventions. Those might have to do with family. It might have to do with particular skill sets. It might have to do with particular types of education. Again, a variety of different possibilities in terms of what those strengths might be. Breadth or how wide do we look at this? Assessing specific risk-need-responsivity factors, but also the other human service needs that may be barriers to pro-social change. But we still have to maintain a focus on the R&R factors. Again, if those factors exist, we need to respond to them. But that doesn't mean we ignore other basic human needs that people might have, or other human service needs that people might have. Interestingly, some of the work out of Canada shows that when you look at dosage, which we'll come back to in a little while, but some of the work out of Canada shows that when you look at dosage, they're combining dosage of the criminogenic risk programming and the human service programming. And they're finding that even when they're combining that, they're getting the better outcomes. In other words, they didn't need all the dosage specifically to deal with criminogenic risk factors. And then lastly, professional discretion, which means deviating from the principles for specified reasons. And there are some reasons that people deviate. Some of them may have to do with what the capacity of the individual is, or what the supports are that they have. Some of it may have to do with what the degree of violence that was involved in a particular behavior, that even if they, quote, are low risk or relatively low need, there may still be an initial period of more intense oversight and involvement, because even though there's much less of a likelihood that they will do something, that something that they do is much more likely to result in something very devastating in terms of another person, public safety, etc. Next slide, please. These are just some of the common risk and need assessment tools. The COMPASS, Correctional Offender Management Profiling for Alternative Sanctions, the PICRA, the Federal Post-Conviction Risk Assessment Tool, the IORNS, Inventory of Offender Risk Needs and Strengths, LSCMI, Level of Service Case Management Inventory, actually revised now, and the LSIR, Level of Service Inventory revised, Offender Profile Index, Offender Screening Tool, a screening tool as opposed to a full risk and needs assessment, Offender Risk Assessment System, the ORAS out of Ohio, and it's been revalidated in different states. Texas uses the TRAS, Indiana uses the IRAS. So different states have taken the fundamentals of the Ohio risk assessment system and then validated them in their own states for use. The risk and needs triage, the risk prediction index, static risk and offender needs guide, or the STRONG, and the Wisconsin risk and need assessment scale. While I personally have my favorites, as most people do, and there are some that I do not like for a number of reasons, that the reality is this, that when we sort of look at it all at the end of the day, all the tools that are in use tend to have reasonable predictive accuracy between about 0.65, which is good, to 0.75, which is really good, with 0 being bad and 1.0 being perfection. To be clear, clinical assessment of these kinds of issues typically is at about 0.50, which is equal to chance. So do tools make this perfect? No, but it increases our accuracy in a lot of ways. And one of the things that the tools actually help do, is limit our own personal bias, that every one of us has some set of biases about other folks. That's just the way that it is. What I do say when I look at these tools, or when I talk to folks about tools, is don't go for the super expensive ones where you're spending all your money keeping them updated. Go for the tools that are reasonably cost effective. Go for the tools that you can get trained on, and that it might be a training cost, but you're not paying in some cases, millions of dollars a year for upkeep in terms of those tools. We can use that money for better things. And again, there is no one perfect tool. And there are probably currently about 30 highly recommended tools. Having said that, there are over 400 in use in the United States. it's silly. We have way too many different tools that we're using across the country that really does not make a lot of sense. That's for another day. Next slide. So I want to talk a little bit about the Justice Center's national guidelines for R&R assessments. And this fits into the section of the expanded R&R model about assessing for risk and need, because this has become a very big issue, and again, understandably so. Several years ago, some concerns were, I'm sorry, next slide, please. Thank you. Several years ago, some concerns were raised about risk and needs assessment, increasing disproportionality and disparity in the criminal justice system. There are a number of news articles, a number of politicians that have spoken about it, and those concerns are valid, and we need to be very careful and real in thinking about it. I will suggest that the concerns were targeting the wrong thing, and that they were targeting risk and need assessment tools that weren't necessarily unpredictive. They were very predictive. They were still showing disparity because the system within which they are predicting is disparate. There's disproportionality. And so, and I'll come back to that. So before we get into that, let's talk a little bit about some of the common terms that are used. The first one is the term of disproportionality, which is a racial or ethnic group is overrepresented among people experiencing a certain outcome compared to the group's representation in the overall population. For example, one state that I'm working in, the population of people of color, it makes up 3% of the state, but it makes up 37% of the jail population. There's a problem there, right? That's disproportionality. Then there's disparity. Differences in treatment, opportunity, or experience for one racial or ethnic group relative to another group. We also, it wasn't criminal justice, but we also saw an article, or many of us saw an article this morning about if you are Black and pregnant in the United States, access to medical care is substandard across the country. And that would be a disparity that we're talking about. What about in terms of criminal justice? It would be the likelihood of being accepted into treatment programming and the likelihood of successfully completing that treatment programming. Bias would be an inappropriate consideration of race or ethnicity in deciding with whom and how to intervene. This is a very real problem with risk and needs assessment, because what we see is that when we do a lot of studies about the implementation of the tool, is that the person who is making the decisions will make different decisions based on the race of the individual being assessed, even when the risk level is the same. And so if someone is Black or Hispanic and the risk level is low or low moderate, and somebody is white and the risk level is low or low moderate, we see situations where there's much more intervention and increased supervision for those people of color than for that person who is white. And we see it happen at a lower level of risk, and then we see it consistently happen all the way through. That is an implementation problem, not a tool problem. And then there's profiling, the use of race or ethnicity as grounds for suspecting someone of having committed an offense. And we all know about that in terms of traffic stops, for example, and many other things. Now, I mention all of these things because a couple things. First of all, risk and needs assessment tools do not increase these if you follow certain objectives and rules that I'll talk about. And secondly, they can't solve these problems by themselves either. Risk and needs assessment tools can't fix a system that is problematic. They can act as a canary in the coal mine in terms of looking at what's happening in a system. And we'll talk a little bit about that as we move forward as well. Next slide, please. So numbers alone can't really tell us why we see disproportionality. There's many, many causes. So there are differences in, first of all, potential explanation for differences in offending rates by populations. One, risk of criminal involvement may be related to educational and economic opportunities. Risk of criminal involvement may be related to the neighborhood. There may be something related to enforcement priorities, gangs, gun violence, high-risk drug transactions, public order issues, or deployment patterns, how police are deployed in terms of public housing, or hotspot policing, or high impact zone policing. And then, of course, the issue of systemic bias, the differential treatment across criminal justice system actors and agencies. And that starts at the very entrance into the system and carries itself all the way through. And then differential resources to navigate the criminal justice system, which is, among other things, means whether or not I have money for a really good lawyer, right? Whether or not I can afford private care as opposed to whatever the community care is that's involved. And I don't mean that as an insult on community care, but what you see are people that use private care when those private care folks make recommendations and they have a high-priced lawyer that are carrying those recommendations through. Interestingly, you see a difference in impact when people are listening to those things. Next slide, please. So what about bias and risk-need-responsivity? Well, again, we have to distinguish where the problem lies. Does the test overrate risk? And we need to make sure it does not, just to be clear. Is it accurate, meaning it is predictively accurate, but cultural factors are indeed the cause of the higher risk? And some examples of that would be the Aboriginal population in Canada, in the United States, African American, Latino, and Hispanic populations. In Australia, the Aboriginal population, and in France, sub-Saharan Africans. And so there are clear cultural factors. Sometimes risk is a measure of the world that the person lives in, as opposed to a measure of internal factors about the individual. And we have to be better at thinking about how to distinguish between those two things. Next slide, please. And so because of that, at BJA's request a few years ago, we started working on developing some national guidelines for accurate, fair, and transparent risk and needs assessments in order to really work on these issues of disparity, of disproportionality, of bias. And so there's 4 components in terms of the work, 4 areas or buckets, if you will, in terms of these guidelines. One is accuracy, predictive accuracy. The second is fairness. The third is transparency. And the fourth is communication and use, which has to do with implementation. And so we'll go through each of these a bit. Next slide, please. So first of all, what do we mean by accuracy? It refers to the degree to which assessment results predict the recidivism outcomes they were designed to predict, as indicated by the observed rate and severity of the criminal behavior, as well as the ability to identify individuals at greater and lesser risk of recidivism. It also involves considering whether the post-conviction risk and needs assessment instruments are completed and used as intended to inform case decisions and plannings within facilities and in the community. Our guidelines, by the way, are specifically for use post-conviction and not for pretrial, just to make that point. And secondly, this piece of used as intended is very important. One of the big problems that we see in implementation is that people will say, I made this decision because of the result of the risk assessment tool, when in fact the risk assessment tool was never designed to be an aid for that particular decision. So it's used as sort of an excuse for a decision that may be more rigid or more problematic than it should be. Next slide, please. There are several guidelines under accuracy. And let me just tell you, there are 13 overall guidelines. I'm going to mention them. Each one of these guidelines have many subcomponents. The document that goes along with this in terms of really looking at this in an in-depth way is on our website. It's 50 odd pages long. We obviously aren't going to go through all of that today, but it is easily accessible for you. And I will also mention something else about this project as we get to the end. So the accuracy guidelines say that, first of all, we need to conduct a local evaluation of the post-conviction tool to ensure that it's suitable for the agency's population. Now, you can't always do that up front. Sometimes you have to have it in place for a couple of years before you can do that. You have to get the samples in place. There's a number of things that you can do. So sometimes we take a quote off-the-shelf tool utilize it for say 2 years or so, and then we begin the evaluation, the validation process. Needs to meet minimum performance standards of post-conviction risk and needs assessments that are completed in the field according to statistical standards. In other words, it has to have that AUC, that predictive accuracy that I was mentioning of between at least 0.65 and preferably around 0.68 to 0.75. Use a continuous quality improvement or CQI process to ensure successful implementation of the instrument, and use a multi-step approach to assess risk and needs over time. In other words, it's not a one and done. We need to be looking at this routinely, if you will, and there's different tools have different suggestions about what that time frame should be, but it's never a one and done. Next slide, please. So what about the issue of fairness? Fairness is the degree to which the results have the same meanings and applications across groups that might be defined by race, ethnicity, gender, or other characteristics such as mental illness, for example. Fairness should be considered in the development of the tool, in the validation of the tool, and in the implementation of the tool. Fairness has to be front and center from the very beginning of the development of the tool all the way through the implementation. And where you see it particularly fall down again, unfortunately, is at the implementation stage. Next slide, please. What are the guidelines here in terms of fairness? Well, the first one is examine the results of the post-conviction risk and needs assessment instrument for predictive bias and disparate impact across groups. Again, remember the earlier definitions that are in this presentation in terms of disparity and bias. Secondly, apply the risk and needs instrument results to individual cases in keeping with the R&R principles. In other words, your case plan, whether that is a supervision case plan or a clinical case plan, should fall within the R&R principle, right? Whichever ones are relevant, if you will, to a particular situation. Thirdly, or number 7, adopt agency-wide strategies to minimize the potential that local implementation of the tool promotes disparities. And this is one of those examples that I was mentioning. I won't mention the state, but another state that I was working in, it was a unified system, meaning the DOC was statewide and parole and probation both within DOC. But there were 2 subgroups, meaning there was a northern and southern region. And when we looked at the results of the northern and southern region, we found tremendous disparity in terms of risk levels. And we started looking at what was going on here. And the disparity in terms of the risk levels had to do with the implementation of the tool, not with the tool itself, and certainly not with the people that were being evaluated, but with how the tools were being used differently. And in one of these 2 areas, they were basically massively overrating the risk and need level of the individuals. So it became a cultural problem of the northern region's parole and probation agents compared to the southern region's parole and probation agents. Next slide, please. Transparency. That refers to how the information about the content, structure, and application of these instruments is disseminated to stakeholders. It's relevant in both the development and implementation of risk and needs assessment instruments, and it requires a proactive communication strategy. A couple of things about this. Well, I'll come back to that. Next slide, please. Here are some of the guidelines here. 1, providing system stakeholders with relevant information on the development, intended use, and validation of the post-conviction risk and needs assessment instrument. There are some developers who say, I can't let you know what's under the hood. And they'll say things like, well, if I let you know what's under the hood, then people will be able to fool the test. My response to that is twofold. 1, it's usually the developers that have a fiscal relationship to the tool that are saying that. So that's part of it. And the second issue is, if in fact my knowing what's being measured is going to distort the measurement, then it's not a very good tool to begin with. And when you look at what tools measure, the assumption that they are measuring something that's just coming out of somebody's mouth who's saying something is inaccurate. And it's a little like me getting a medical test and not being allowed to ask, what is that medical test showing and how has it been developed? Makes no sense at all. 9, develop a written policy that guides the local use of the post-conviction risk and needs assessment instrument. And 10, communicate the strengths and limitations of post-conviction risk and needs assessment instruments to the general public. These are not magic bullets. They all have certain strengths. They all have limitations. They are not the only answer, the only solution, or for that matter, the only assessment that should often be done, right? We should also be looking at, in many instances, mental health screens, substance use screens, / full assessments. We need to be looking at issues of assessing, again, for things like food insecurity, housing issues, other kinds of education issues. There are many other areas that, in addition to this, we need to look at. Even when a tool has some of those components in it, it's not typically to the degree that it gives us the full assessment. And so we shouldn't make believe that they are the end all be all. They are a necessary, absolutely necessary, but not sufficient assessment component of the work that we do with people that are in the criminal legal system. Next slide, please. Communication and use. The manner in which individual assessment results are communicated and how they're used can greatly affect their impact on decision-making and consequently their effectiveness. And that is in several ways. One, if all I do is talk to an advocacy group who are advocates for folks who've been hurt and simply say, well, he's low risk, and that's all I say, well, they're like, you're excusing this individual. Well, that's not what the point is. We need to be explaining to them what those issues are, what we're going to do, what doesn't make sense to do, why it doesn't make sense, why we're concerned about community safety, and why, if we do certain things, will actually decrease community safety. Or we're talking to the client himself or herself, and we just look at him and go, you're high risk. And what does that mean? And what are we going to do? As opposed to, well, what are the top 3 or 4 needs that we're seeing here? How can we help? Massachusetts does some really nice work with this. I only mention states when I have something good to say, as opposed to a concern. Massachusetts does some really nice things with this, and where they really work jointly with the client. After the assessment results are back, they explain it to them, they sit down with them, and they say, so here's the top 3 or 4. Which one do you want to work on first? Let's decide how we want to move this forward. Now, are there ever exceptions to that? Of course, if there's an immediate community safety risk, immediate violence risk, then obviously they're going to have to make some decisions. But generally speaking, the majority of the time, that's not the case. And so they're literally engaging the individual, and they're engaging that individual in a way that says, I want to work with you with the results of this to help you move forward, to help you be successful, as opposed to, oh my goodness, I need to watch you so closely because you are high risk. Improper communication of the results can undermine efforts to promote accuracy, fairness, and transparency when we're using these instruments, and they need to be a key consideration in their implementation. Even good tools can be misused, and we need to really be on top of this particular area to ensure that they are used well. Next slide, please. Some additional communication and use guidelines. Anchor the communication of the assessment results, again, in the R&R principles, as the example I actually just gave in terms of Massachusetts. Contextualize the results of the risk and needs assessment instruments. In other words, don't just sort of throw out the lingo, make sure you're speaking in a language that people understand, and then contextualize it in the sense of, this is what we need to do, this is where we need to go, this is how it can help, as opposed to just, you're this, you're this, you're this, so I'm going to give you program A, program B, program C. Again, in our 50-odd page document, we have a lot of content under each one of these items, far more in depth than what I can do in the time that we have today. And then 13, develop a template for communicating individual results of post-conviction risk and needs assessment instruments to all of the relevant stakeholders, including the person being assessed. And that's really important. It's not fair. It's really not fair to the supervising officer, when it is the supervising officer that is doing this, to expect him or her to, on their own, develop how they're going to do this. we need to really develop a template that says, here's how we do this in this agency or in this organization, if we're doing it in a community agency, and how we're doing it in this probation or parole agency, if that's where we're doing that. So that it is consistent across that. It is consistent and doesn't change from officer to officer. That when an officer or a clinician changes from one to another, because sometimes there's turnover for whatever reason, that the way that person talks to the client, probation or parolee, isn't suddenly different, using a different language, and it confuses the client. So again, lots of ways to really make sure that we're developing that. One of the things that I often say to agencies around this is that if you have a comms department, this is the time to call them in and really let them help you develop this component of what it is that you need to be doing. Next slide, please. I mentioned dosage earlier. Now, there's not a lot of studies on dosage, to be fair, but there are several out there now. And the findings from each of them are pretty similar. The main difference that we've seen, I sort of alluded to earlier, in Canada and in England, when they count, or the United Kingdom, they count dosage, they count both criminogenic risk programming, cognitive programming designed to lower criminogenic risk, and human service programming, mental health, substance use, other programming. So they've combined those in terms of meeting the dosage numbers. In the US, the tendency is to stick with the cognitive programs. I have been suggesting lately we should rethink that in terms of what we now know about the impacts of these other areas on folks' lives. But fundamentally, what it says is if somebody is very low in terms of their risk, and this is a 4-level model, some people use a 3-level model, some people use a 5-level model. Arguably, 5-level gives us the best disaggregation of individuals, of folks. But for those folks that are low, minimal. I mean, really, just let me put it this way: leaving them alone is a really good idea. There's very little we can do that won't actually be harmful, so we should leave them alone. And again, we're talking about intervention specifically related to criminal behavior, criminal recidivism likelihood. If somebody is very low but has a mental health need, we should be referring them to mental health treatment or to whatever other need they have. What we shouldn't then be doing is violating them if they don't go. They get to decide, just like the average citizen gets to decide, whether they are going to go to that treatment or avail themselves of whatever the service is. We don't punish them for not doing something that might help them, but that in fact is not related to the likelihood of new crime, just to the likelihood of their life not being as good as it could be. Okay. Then we talk about folks in terms of moderate risk, and that's where you would see folks typically once a week or so, 3 to 6 months, about 100 hours. And they've broken it out in these different ways because depending on whether it's outpatient or residential or if you're incarcerated, how many times you can meet, what you can do, changes pretty dramatically. So they've broken them out in these different ways. But for moderate, we're talking about roughly 100 hours. Studies actually say 50 to 100. When we're talking about moderate high risk, we're talking about 6 to 9 months, typically about 200 hours or so. Again, studies, they tend to say 125 to 200. So these are the upper levels of these things. And then for high, twice a week or possibly residential, and residential might mean while you're incarcerated, 9 to 18 months in terms of programming, might be 300 hours. For the very, very high, it might be more than 300 hours. One point about this, though, when it talks about 9 to 18 months in terms of intensity or residential, there is not a good rationale for keeping people incarcerated to complete treatment. And unfortunately, there's a number of states that do that. And that doesn't make sense. It makes sense to make sure you've got a solid basic treatment going on, but to deny somebody who's eligible for release just because they haven't completed programming yet. And I'm not talking about people who refuse to start, people who refuse to be involved. I'm talking about, no, I've been working for 10 months and now I'm eligible, but you're telling me that because I have another 6 months to complete this programming, I can't leave. That is not a good idea. That should be continued in the community so they can continue the programming, but you do so once they're back in the community. Next slide, please. And so as we loop back to then finishing up the 18 areas when we talk about the R&R model. This includes treatment staff practices, which includes relationship and structuring skills. Relationship skills include warmth, respect, and being collaborative. By the way, those relationship skills are not specifically for clinical staff. Those relationship skills are for supervising officers. Those relationship skills are for people providing the cognitive programming, whether that's in a prison or in the community, if they're not clinicians. Structuring skills includes modeling, reinforcement, skill building, problem solving, cognitive restructuring, and other validated structuring strategies. And that issue of modeling, so first of all, reinforcement needs to be much more positive reinforcement than negative reinforcement. And we often talk about it needs to be a 4-to-1. The research on that is somewhat limited, but what we do know is that there needs to be more positive reinforcement than negative reinforcement in terms of folks changing. And the modeling piece is really important, right? If you model a do as I say and not as I do, as an officer, as a supervisor, as a program person, then all you're teaching the person is that when they're out from under your thumb, they can be mean too. I also have seen this sometimes in treatment programming. I've seen it particularly in specialized programming when we're talking about problem sexual behavior or interpersonal violence. I've often, not often is unfair, I have seen many times that the providers themselves are really modeling very, very bad behavior, very abusive behavior toward those individuals, which needless to say, does not change how they're doing. I've also seen many very good programs that model excellent, appropriate behavior for the individuals they're working with. Skill building is important. There's some people who have the theory that these folks actually know what they're supposed to do. It's all deep inside. And so the problem is that they don't do it. It's kind of silly thinking. Actually, they don't know what they need to do. They did not learn those skills. They did not wake up one day after having a wonderful, perfect life and suddenly decide I'm going to do something that turns everything upside down. They are folks who typically, for a very long period of time, have either not developed certain things or have had things happening to them that have led them to this point in time. They do not have what they need. Our job is to help them get or develop what they need. That's what we need to be doing. We are helping fill them, if you will, with skill sets. They are not going to discover it deep down. That is, to be blunt again, sort of another middle class error. It's all in there. No, folks, it's not always in there. And there's good reasons why it's not in there. And it's not necessarily because of something always bad, and I use the word bad in air quotes, about them. It has to do with what opportunities they did not have to get those things developed. And then problem solving, cognitive restructuring, very obvious, again, components of that work. Next slide, please. So what about the organizational components of the treatment programs when we're talking about setting and management? Well, community-based programming of all sorts should adhere to let me rephrase that are dealing with these clients, should adhere to R&R because they are more effective. The services are more effective when they're delivered in the community. That's not to say that we shouldn't provide services when they are incarcerated or if they are in a residential setting. There are times when they have to be in those services. Those should be seen, if you have nothing in the community and the person's incarcerated and they get that, that is absolutely a fine thing to do. If you have services in the community, the ideal is get them, if they are incarcerated or in a residential setting of some other type, the ideal would be get them started while they are inside and then finish it up when they are on the outside. And by the way, finish up on the outside doesn't mean make them do the same thing all over again. There needs to be a continuum. Whatever they've gotten for the base while they are inside, wherever inside is, should then be built upon when they get to the outside. In terms of continuity of services, there needs to be ongoing services from, if they have been, again, in a facility of any type, needs to be ongoing services and monitoring of progress as they move from inside to outside. Managers should really be selecting and training the staff according to their interpersonal and facilitation skills, provide clinical supervision according to R&R, and ensure that there are organizational mechanisms to maintain the monitoring, evaluation, and integrity of assessments and programs. Back before I've been with the Justice Center for about 13 years now. Prior to that, I worked in the field for about 35 years. and among other things, oversaw a number of clinical programs, always at the intersection of behavioral health and criminal justice, various types of programming. And we did a lot of different kinds of work, both in terms of traditional cognitive programming like reasoning and rehabilitation, cognitive behavioral therapy, motivational interviewing and engagement. About a third of my staff, including those who were clinical, could not do motivational engagement to save their lives. They just weren't wired to do it. And so part of what we needed to do is to really think about what were the different strengths and skill sets of our staff and who did we have doing different things, so that we weren't basically either creating a bad situation for the client or making the clinician miserable, if you will. And I've done a lot of training of probation and parole supervisors over the course of my career as well. And the same holds true there. You need to really, one, think a lot more about what skills we want when we hire. And then secondly, because not everybody is good at everything, we need to decide how to best place folks dependent on which skills they are best at. And then lastly, community linkages. The agency where the program is housed should maintain positive relationships with other agencies and organizations. We're not talking about breaking any HIPAA rules or CFR 42 rules, but a lot of times you see programs, I guess I don't have a nice way to say this. A lot of times you see programs hide behind those as a way to not communicate at all. That is unfair to the client. And obviously a client has control over what is communicated, but generally speaking, they are in much better shape when we are working collaboratively with whatever the other organizations are that are involved in that person's life. It lessens the likelihood of them falling through the gaps or the cracks, if you will, and it lessens the likelihood that one of the organizations will do something that negatively interferes with what the other organization or agency is trying to do. Next slide, please. Ignoring assessment results and ignoring R&R results or can result in over-supervision and over-programming. Multiple studies across the country have shown that supervision staff practices are often misaligned with the research on risk, need, and responsivity and associated with agency trainings. The problem is not that the officers use the assessment to make case planning decisions, but that they ignore or override the results, which leads to overrating the potential for recidivism, over responding to client needs through over supervision, over programming, focusing on the wrong needs, or making unnecessary program referrals. Anger management is one of those common things that so many people get sent to, that there's often not a real connection between what that program has to offer for that particular individual and what that individual needs. And there are other similar examples. You see this happen sometimes with substance use, where courts order substance use treatment when once they get to the substance use program, the assessment says that really doesn't fit here, it doesn't make sense. Ignoring the assessment results creates greater disparity in responses compared to following the recommendations of a correctly validated tool that is used on the intended population for the intended reason that the tool was developed. Next slide, please. And that leads us to questions and answers. I appreciate all of you who have listened and the 137 of you that are still here. And so if there are any questions, Ethan or Steve or anybody wants to let me know and try to answer them.
Thanks, David. Eunice, if you want to go, I think to the next slide there, perfect. And we'll begin the question and answer portion of the webinar. Again, please type your questions for the panelists using the Q&A button, and we'll respond to as many as we can in the time that's remaining. David, I'm going to throw you the first couple that have come in here, and I'm going to try and group the juvenile ones together to start. That way we're not bouncing back and forth. So one person asked if the information in the R&R assessments, is there any information that's different between the youth justice R&R versus an adult?
In terms of the overarching model, no. And in terms of the overarching model, it would be the same model. And in fact, in terms of the original validation of the model, many of the individuals in the original sample size were individuals who began their involvement when they were adolescents. Having said that, the tools are different. And some of the specific things the tools look at are different when you're assessing a juvenile versus an adult. And to be fair, all of the tools that I was showing you were specifically focused in terms of adults. The juvenile tools tend to, juvenile tools have done a much better job of not getting caught up on the risk idea and really focusing on the need area and what those needs are. And there's a number of, there's 3 or 4 really good tools out there. There's probably about 15 to 20 tools out there, but there's 3 or 4 that I think have pretty solid research behind them. If whoever asked that is interested, I am happy to put you in contact with a colleague of mine. I live in Connecticut. Not that any of you would know that, but I live in Connecticut. I'll put you in contact with a colleague of mine who's developed one of the better tools that's utilized with juveniles, as well as send you a couple of other connections, and you can email any of the team and they'll forward it to me, and I'm happy to get that information to you.
Thanks, David. And that came in from an anonymous person. So if they want to send us their contact information, we can push that over. I'm following up, Dave, with another question about intervention dosage. And is that the same for juveniles and adults?
Those dosage studies were on adults specifically. And so the answer to that would be no. And I would actually argue that, particularly when you get to the right side of that chart, where you get to that 200, 300 hours, 200 and 300 hours in the life of a 40-year-old is very different than 200 to 300 hours in the life of a 13 or 15-year-old. We need to be careful to not over-respond to juveniles. And so those studies were not, the samples in those studies were not with juveniles. So you want to be very careful about that. I've seen a lot of situations where they put juveniles in treatment for like 2 years, 3 years. And I'm not talking about mental health needs or whatever, again, focusing on criminal legal issues. You know, what we know is with brain development that things change as quickly as 6 months, right? When we're talking about adolescents, right up to young adults. And so we really need to be very, we need to be much more parsimonious in terms of dosage when we're talking about juveniles than when we're talking about adults.
Thanks, David. Next question's coming in is, how can agencies ensure that professional discretion does not encourage bias or gut reactions, particularly among the community supervision staff?
Yeah, so the number of things. One is having coaches in place. 2 is having a Q&A process that you're able to routinely, and routinely might mean once yearly, whatever, might mean twice yearly. It depends. Some of it depends on the size of the agency. Sorry, but first of all, there should be a determination of what the override percentage should be. In other words, a lot of the tools actually say, if you're more than 10%, if you have more than 10% override of using this tool, this tool is being misused. Other agencies have said, anytime we have more than X percentage override happening, we're going to start examining all of those overrides and figure out what the problem is, because we're going to initially assume that the problem is probably an implementation problem and not an issue that's related to the clients. And so that's 2. And then 3, there are a number of dashboards out there that one can use that different folks use around the country, where they're able to sort of match in real time and look at, these are the results for, these are Joe's results, these are Jill's results, this is Jack's results. And, Jill has a 5% override and Joe has a 6% override and Jack has a 22% override. We have a problem here. We better look at this and see what's going on. So one, you can have policies that say, there's an automatic triggering of checking things if we go over a certain percentage. And then secondly, you do have to have an oversight model in place, whether that's coaching and QA, whether that's a dashboard model. You have to have something and not just leave people to their own devices. And to be clear, that doesn't mean those people are purposely trying to do the wrong thing. The best of us with the best of intentions sometimes can make some pretty big mistakes about these things.
Thank you, David. I'm going to slide in towards the dosage now that we were talking about. One of the first ones that questions that came in was stating if we're not to violate individuals if they don't attend mental health appointments. What if the individual is court ordered to attend mental health treatment? And what about the individual who self-medicates instead of using their medications?
So sort of a number of different issues that let's unpack that a little bit. The first one is there are many times when somebody who's supervising an individual or as a referral when there's a court order, and that does take some things out of our hands, right? And if we have a judge that says this is what this person's going to do, there are times when we have no choice but to follow that. There are other times when we can go to the judge and we can say, hey, judge, we have additional information here, and we get why this happened, but can we have a revision of the stipulation? I work in a state that fortunate that they don't have to go back to court to do that. The probation department has the leeway to do the assessment, make the decisions. And so the judge says, you will follow whatever the results of the assessment say that need to happen. So that's one. Two, the issue of, so that's the court order. The second issue is the issue of self-medicating. Well, again, we need to unpack that a little bit. Are they in the lowest risk category? If they're in the lowest risk category, in my opinion, doesn't change. If they are in the higher risk categories, well, now you've got a bit of a problem because there's a direct relationship. The other question is, what does self-medicating mean? Are they self-medicating because they're smoking a lot of marijuana and you live in a state where marijuana is not legal? Or they're self-medicating in a state where what they're using is an illegal drug, which means they're committing a new crime, which is a problem. And so you're probably in a situation where you need to really be reinforcing that person getting into programming, whatever that programming might be. In this case, perhaps substance use treatment or perhaps mental health treatment. So part of that, the answer to that question depends on whether or not they are in the lowest risk bin to begin with, whether or not what they're self-medicating with is another crime, and whether or not there's a relationship between that behavior and general crime. In other words, obviously, if somebody has committed a crime while using a substance, what I said earlier doesn't count, right? At that point, you have a direct integrated correlation between the use of that substance, and the crime. In order to lower the crime, you've got to deal with the substance use issue, right? You're rarely going to get somebody in that scenario who falls in your lowest risk bin. You never say never, but that's rarely going to be the case. It's usually going to be at the very least in the next bin that's going to suggest some type of intervention. So what I was really talking about was that lowest risk bin, no criminogenic factors, not related to the crime, and they might have some needs, and we should certainly help them get those needs met. But if it is a need that if they were not on supervision, we wouldn't be arresting them for, then we shouldn't be arresting them, technically violating them for doing that now. Again, as we move up in levels of risk, that dynamic changes.
Thanks, David. Sticking with dosage, there's a couple questions I'm going to try and combine here, specifically dosage translating to probation supervision versus the treatment. We have a couple of questions coming in about what supervision levels for dosage are we applying if the probation's using CBT, and then is there a difference in contact between office setting or community settings for probation?
So here's what I think you're saying. The question is, does supervision contact count as dosage? And the second question is there a difference if that happens in the supervision office versus in the community or versus a community agency?
Got it.
Okay, so maybe. It depends on what's going on in that contact. If the supervision contact is, hi, how are you? How's your wife doing? Did you go to work today? Did you keep your curfew? Then no, it really doesn't count. That's just a check the box kind of routine. If the supervision contact is something that is focusing on one of the identified needs and working with that individual about what that was like in terms of that week, what that person did, chatting with that person about what happened in programming, essentially doing something that is designed not to check the boxes about where they were which you may need to do. I don't mean to insult that. You may have to fill out those things. But if that's all you do, in some places, they've got 10 minutes. That's all they can do. That doesn't count. In other places, they have 30 minutes or they have 35 minutes and they spend 5 minutes with the things that they need to do to keep records for, and they spend the balance of the time focusing on those things that are related to the needs that the individual has. In that case, yes, that would count toward the dosage. Whether it's the difference between whether it happens in the probation office or parole office and a community program depends on what's occurring when that person is in the supervision office. If you're using carry guides, that would count, right? If you are using any of the kinds of programming, not necessarily doing a program, but using components from them. If you're doing motivational engagement kinds of things, if again, you are focusing on the specific areas, maybe the acute risk factors and making sure that they're doing well with those, then that can count towards dosage. But if it's a 10-minute meet and greet, you made curfew and you didn't do this and you didn't do that, that really doesn't count towards dosage because there's no outcome to that in terms of behavior change on the part of the individual. I think I answered both parts of that, Steve.
Very well. I think you did too. And that was very good information there. Two things. One, Eunice, could you slide us back to page 40 in the slide? And while she does that, David, I have a different question. And for sex offenders, how does the dosage suggestion work if a residential is 300 hours? Are there other criminogenic needs picked up in those 300 hours, or are there other dosage hours on top of the 300?
Should there be only, should the 300 hours be only sex offender specific treatment? I think that's the question.
Yes.
So let me start with, we tend to over-treat people with problem sexual behavior. We tend to assume that they are all higher risk. Yet when you look at recidivism data and when you look at actual objective assessment data, they are not. So that's sort of the good news. The second issue is, can other things be included in that 300 hours? There should be other things included in that 300 hours. And by the way, at the highest level, when you look at the studies themselves, it actually says 300 plus. Again, this slide is sort of making it more discrete than in truth when you look at the data, when you look at the studies, the way that it is, the studies say 50 to 100, a moderate high, 200, 150 to 200, et cetera. And to be clear, the studies, and I'm thinking of McGrath's particular work here, where he was looking at sex offense specific, he was clearly talking about a combination of in the facility and in the community. When you have somebody who has problem sexual behavior that is at a level that he, and it'll typically be a he, requires 300 or more hours of intervention, it would be very rare that there aren't other co-occurring problems that individual's having. And so to focus only on the problem sexual behavior issues is probably missing some very key issues. And so that would be my response of, you should never only focus on that. And then the second one is, when you look at the actual studies, it says 300 plus. And so part of what you have to do is to really assess what you're dealing with here, right? In terms of what this individual's needs are. And it is possible that somebody will have such a wide group of co-occurring needs that, yeah, it might be 400 hours and 100 of those, it might be 100 of those hours are not sex offense specific, and they might need the 300. The studies are not that, how do I want to put this? They're not that solid that you should just sort of take them without having some real thinking about what are the particular needs of this individual and what do I have to do in order to make sure I'm meeting the needs of that individual. Again, when you look at the actual studies themselves, at the high end, it says 300 plus, which gives you some room because, people are different.
Thanks, David. I want to jump back to this slide here. Someone asked if this risk level model showing is based off of a specific risk assessment tool.
No, this is not based off of a tool. This is based off the what you see here, the framework from NIC, which is based on studies done by Daryl Kroner, Ed Latessa. I forgot his name, out of Canada and England. There's another person who I should remember his name because I know him, but I'm spacing on it. And McGrath. And so there are several studies out there, and this comes from the combination of those studies. It does not come from a specific tool. There are not really tools. I mean, I saw in the chat somewhere somebody was using the George Mason tool, and that tool has built some of those things in. But generally speaking, the tools don't give a specific, like if I were using LSCMI, it doesn't then say to me, well, and so you give 72 hours to this individual. It doesn't do that sort of thing. So this was developed from the various studies that are out there, as opposed to specifically from one tool.
Thanks again, David. Eunice, could you slap us back over to the last slide, please? Awesome. There are a handful more questions still coming in, so I know we're at time, so I don't want to hold anybody over. I'm going to ask if you want to send those questions in, and we can forward them over to David. There's the information there to contact Ethan Kelly, and he'll do his best to get that information to David and then back at you. And if you would like to get your contact information over to David, you can do that as well. David, thank you. Obviously, again, we really appreciate your participation. Your expertise in this area is unmatched, and all of your insights. And with that, I believe we're going to wrap things up. And this program is being recorded, so it'll be available on our website, which is also listed there, within the next 1 or 2 weeks. Thank you, everybody, for participating. Again, thank you, David, for everything.
Yeah, thanks, David. You're very welcome. Thank you, everybody. Take care.